This morning, we have the pleasure of having Dr. Hooman discussing pulmonary hypertension. Dr. Poor received his bachelor's degree from Dartmouth, where he majored in physical chemistry and mathematics. He received his medical degree from Columbia, where he also completed training in internal medicine and pulmonary and critical care. He has been at Mount Sinai since 2013, where he has dual appointments as assistant professor of medicine in the Division of Cardiology and Pulmonary Medicine. He is the director of pulmonary vascular diseases for the Mount Sinai-National Jewish Health Respiratory Institute, as well as the founder of the multidisciplinary pulmonary embolism response team here at Mount Sinai. Dr. Poor is also the assistant program director for the Pulmonary and Critical Care Fellowship Training Program and the course director for the Pulmonary Pathophysiology course for the second-year medical students. He is a beloved educator among students and house staff, having received numerous teaching awards and recently published a textbook entitled Basics of Mechanical Ventilation. Please join us in welcoming Dr. Poor.
Good morning. Thank you all for coming, and thank you for inviting me. Today I'm going to talk about pulmonary hypertension. This is actually how we measure pulmonary pressure, as we put a cuff around the lungs. I have no financial disclosures. So this is a common case that I saw in the emergency department recently. A 39-year-old woman who presented with a few weeks of worsening dyspnea on exertion. She'd been short of breath after walking only about a half a block. Prior to this, she was extremely active. An echocardiogram is performed. She has normal LV function and size, an EF of 75%, and she has a severely dilated right ventricle, and the RV systolic function is severely reduced. Her estimated RVSP is 90. So what do? Do you do nothing? The LV is fine, and that's all that matters. Do you prescribe a calcium channel blocker? You start with this class of medication first to see if it works. Do you prescribe sildenafil? It's now generic and is a better pulmonary vasodilator than calcium channel blockers. Or do you hide in the bathroom? PAH patients are hemodynamically tenuous and code if you glance at them the wrong way. Or do you begin the workup to better characterize her pulmonary hypertension? So I'm being a little bit facetious with respect to A through D. However, I have seen all of them happen. And my hope is that after this talk, we'll get closer to E. So specifically, I'm going to talk about the physiology of the pulmonary circulation, the classification of pulmonary hypertension, the pathophysiology of pulmonary arterial hypertension, the vicious cycle of RV failure, the treatment of pulmonary arterial hypertension, and then I'm going to touch on pulmonary hypertension secondary to heart failure with preserved VF. So the pulmonary circulation is characterized by a low pressure circuit. You can see here a depiction of the circulation here. The left ventricle pumps into a high pressure circuit. You can see that the mean arterial pressure is about 93, and by the time you get to the capillary bed, a lot of that pressure has dissipated down to about 30, and you come back to a low pressure of a right atrial pressure of about 2. The pulmonary circulation, on the other hand, the mean PA pressure is about 14, so much lower, and by the time you get to the capillary bed, very little has dissipated, and you come back to a left atrial pressure of about 5. And so the house staff here is probably having PTSD when they see this slide, only because every time I discuss anything, I talk about Ohm's law, which is a voltage difference across a resistor is equal to the current of electrons times the resistance. And we can apply this to the pulmonary circulation. Instead of a voltage difference, we have a pressure difference. Instead of a flow of electrons, we have a flow of blood, and that's the cardiac output. And the resistance here is a pulmonary vascular resistance. The pressure difference that we're looking at is the pressure difference between the pulmonary artery and the left atrium. And when we rearrange the equation, we now have an equation for the pulmonary arterial pressure. And you can do the same exact thing for the systemic pressure. The cardiac outputs are the same if there are no crazy shunts. Instead, you have the systemic vascular resistance, and the downstream pressure is the right atrial pressure. So if the cardiac outputs are the same, and the right and left atrial pressures are both very low and about the same, then the reason that the pulmonary pressure is so much lower than the systemic pressure is because pulmonary vascular resistance is low. And that is essentially the hallmark of the pulmonary circulation. And the resistance is low because of less muscle and elastin in the vessels, and also this concept of capillary recruitment. So your capillaries often, particularly those in the higher lung zones, may be compressed, When blood flow increases in them because of, say, exercise, they will dilate. And when they dilate, the cross-sectional area of the vessels go up, and therefore the resistance goes down. So the definition of pulmonary hypertension is a mean pulmonary arterial pressure of greater than 20 at rest, measured by right heart catheterization. And it's important to note that this pressure has been changed about a year and a half ago. It used to be a pressure of greater than 25. And that's because this pressure of 25 was sort of randomly plucked out of the air. And it really was because of this study by Kovacs in 2009, a meta-analysis of 47 studies from 13 countries. And they took about 1,200 asymptomatic individuals, no issues, who underwent right heart catheterization both at rest and with exercise. And they found that the average mean pulmonary arterial pressure was 14, with a standard deviation of 3. So if you do 2 standard deviations above the mean, you now have 20 as your kind of cutoff. So the classification of pulmonary hypertension has classically been primary versus secondary pulmonary hypertension. I highly advocate that you do not use this classification. It's an older classification. And the newer classifications are based on the World Symposia on Pulmonary Hypertension. The first one was convened in Geneva in 1973 in response to this rise in the incidence of, at that time, primary pulmonary hypertension, secondary to the anorexigen Aminerex. And then in 1998, Evian, France was the next symposium. And this is where the kind of foundation of our new classification was developed. And every 5 years, this symposium meets. In Venice in 2003, Dana Point in 2008, in Nice in 2013. And then they thought Nice was nice, so they went back there again in 2018. The only reason I show this is mainly for the house staff. When you're choosing a specialty or subspecialty, it's really important to look at where your conferences are held. I'm told the next one's actually in Jersey. I'm not kidding. So to understand the causes of pulmonary hypertension, again, the definition is a mean PA pressure greater than 20 at rest. We go back to this equation. So if the PA pressure is high, either the cardiac output is high, the pulmonary vascular resistance is high, or the left atrial pressure is high, or some combination of the three is high. So with respect to increased cardiac output, this can occur from congenital heart defects with a left to right shunt, an ASD or VSD, cirrhosis, other high output states like anemia, AV malformations, AV fistulas. We recently had, actually a few months ago, a young woman present in multi-organ failure, RV dysfunction, severe pulmonary hypertension, and ultimately we diagnosed her with thiamine deficiency. And we literally discharged her on thiamine and her home syndrome. So it's the craziest case I've seen in a while. Increased left atrial pressure. You can have systolic and diastolic left ventricular failure, valvular disease on the left side, mitral or aortic valve disease, restrictive cardiomyopathy. And then the increase in pulmonary vascular resistance comes in different flavors. You can have destruction or obliteration of the pulmonary vascular bed from ILD, say fibrosis or inflammation. Also emphysema can destroy the vascular bed. And then obviously PE and clot will obstruct the bed. Hypoxia is a very strong stimulus for pulmonary vascular constriction. It can either be from a disease like COPD or the ambient air, for example, at high altitude will cause pulmonary vascular constriction. And then there's a very specific small pulmonary arterial vasculopathy, and that is called pulmonary arterial hypertension. And so the World Health Organization classification, this is the most recent one from Nice, breaks down the pulmonary hypertension into 5 groups, the WHO groups. Group 1 is known as pulmonary arterial hypertension. That is the very specific vasculopathy, which increases pulmonary vascular resistance and secondary to these causes here. Group 2 is secondary to left heart disease. That is an increase in left atrial pressure that has caused this. Group 3 is lung disease and hypoxia, which increases pulmonary vascular resistance. Group 4 is pulmonary artery obstructions, the main one being chronic thromboembolic pulmonary hypertension, that's clot, that increases pulmonary vascular resistance. And group 5 is everything they couldn't fit into 1 through 4. And so one of the major reasons why I think primary versus secondary is not a very helpful classification is that if you were to tell me that a patient has pulmonary hypertension secondary to scleroderma, Scleroderma can cause this very specific vasculopathy known as PAH. Scleroderma can cause left heart disease and cardiac fibrosis. Scleroderma can cause pulmonary fibrosis and hypoxia. And scleroderma probably increases your risk for developing blood clots. So knowing that you have scleroderma, while it's helpful, doesn't really give you the whole story. Additionally, it's important to note that primary pulmonary hypertension really just refers to these three rare conditions, and that the majority of patients, orders of magnitude higher in prevalence, have pulmonary hypertension secondary to left heart disease or lung disease. So a few hemodynamic definitions. It's important to note that pulmonary arterial hypertension and pulmonary hypertension are not the same thing. Pulmonary hypertension merely means that the pressure is elevated in the pulmonary arterial tree. Pulmonary arterial hypertension is a subset of pulmonary hypertension, a very specific vasculopathy with these hemodynamic parameters. It's also important to note that group 3, which is lung disease and hypoxia, and group 4, which is the large artery obstructions, have the same hemodynamic profile as group 1. You can't tell the difference based solely on their hemodynamics. The other aspect about the definition of pulmonary hypertension is that exercise criteria is no longer part of that definition. Previously, if you exercised a patient and their mean pulmonary arterial pressure went higher than 30, that was deemed exercise-induced PH. And again, this is because of that study by Kovacs, where these asymptomatic patients underwent right heart catheterization at rest and also with exercise. And they found that even with just slight exercise, half of the patients who are older than 50 years old had a mean PA pressure greater than 30. So if you have half the patients who are greater than 50 with just mild exercise, having this increase in pressure who are asymptomatic, you can't really call that a disease. And you can imagine why that would happen. When you exercise, your cardiac output goes up, and therefore your PA pressure goes up. Notably, your vascular resistance should go down because your blood vessels should dilate. There is a condition of exercise-induced PH, but it's much more complex than just a fixed number of greater than 30, and that's why it was removed. So to understand pulmonary hypertension, it's helpful to understand pulmonary arterial hypertension as the foundation. And so this is a normal pulmonary artery. You have the intimal layer here with the endothelial cells, the smooth muscle cells in the tunica media, and then the adventitial layer. And the lesions that occur are fibrotic and proliferative lesions in the small muscular arteries. The types of lesions that occur and the changes that occur in PAH include vasoconstriction, so the smooth muscle cells actually vasoconstrict. You get actual remodeling of all three layers, so the intimal layer will thicken, become fibrotic. You'll get smooth muscle hypertrophy and hyperplasia, and then adventitial thickening as well as inflammation with lymphoid follicles. There is this very strange lesion known as a plexiform lesion. Areas of injury occur with endothelial cells now break into the artery and occlude the artery. And then you can also develop in situ thrombosis. And all of these, as you can imagine, decrease cross-sectional area and increase pulmonary vascular resistance. And the pathogenesis involves kind of the trinity of pathways. The endothelin pathway in these patients is upregulated. Endothelin results in vasoconstriction and proliferation of smooth muscle cells and remodeling. The nitric oxide pathway is downregulated. Nitric oxide leads to increased cyclic GMP. Cyclic GMP is vasodilatory and antiproliferative. And the prostacyclin pathway is downregulated. Prostacyclin results in increased cyclic AMP, and it's vasodilatory and antiproliferative. So diving deeper into group 1, we can break this group into other subsets. There's the idiopathic form. There's the heritable form. 70% of those with the heritable form have a germline mutation in the bone morphogenic protein receptor 2. However, it's important to note that only 20% of those who have the mutation will develop PAH, so the penetrance is relatively low. There's drug and toxin-induced chemotherapeutic agents like dasatinib, anorexogens like fen-phen and amenarex, and illicits, most recently being crystal meth being a huge rise in the incidence of PAH. And then there's the associated PAH, connective tissue diseases, specifically scleroderma and lupus. And congenital heart disease, as I mentioned before, you have left to right shunt where you have increased flow and pressure through the right side of the heart and the pulmonary vasculature. That high pressure and flow will cause injury to the vessels and result in PAH. Portal hypertension, the idea is that blood bypasses the liver and certain toxins now injure the pulmonary circulation. HIV and worldwide schistosomiasis is a big cause. The epidemiology of PAH, it's a relatively rare disease. The prevalence is about 15 to 50 per 1 million adults, but the prevalence varies amongst specific patient populations. So in scleroderma, 10 to 15% will develop group 1 PAH. Portal hypertension ranges from 2 to 16%. And in congenital heart disease, if you don't have your ASC repaired, it's about 10%. If you don't have your VSC repaired, it's about 50%. Within PAH, half are idiopathic and about half are associated, with a small percentage heritable. And within the associated, half are collagen vascular disease, about 20% congenital heart disease, 10% portal hypertension, drugs and toxins, HIV. It's a deadly disease. Median survival of untreated idiopathic PAH is about 2.8 years, and survival at 5 years is 34%. And this survival varies depending upon the demographics. So those who have congenital heart disease have the highest survival. 5-year survival is in the 80% range. Those with collagen vascular disease, much worse, and idiopathic is right in between. And if you take certain disorders who are at high risk, for example, scleroderma, patients with limited scleroderma without PAH have survivals around 80% at 5 years. A patient with limited scleroderma with PAH has a dramatically lower survival, about 10% at 5 years. So you can imagine in very specific patient populations, it is a major cause of morbidity and mortality. So the underlying lesion in pulmonary arterial hypertension is a vasculopathy of the pulmonary arterial tree. However, the cause of symptoms and mortality is because of right ventricular failure. And the question is, we see tons of patients with systemic hypertension. Why is it that patients with systemic hypertension don't have median survivals of 2.8 years? And the answer is that the pump behind the circulations are different, the right and left ventricles. Classically, the right ventricle has been viewed as merely a weak version of the left ventricle, but it turns out that's not the complete story. They are embryologically different. The right and left ventricles, myocardium arise from different origins, and they're structurally different. This is a short axis view. We've basically cut the heart crosswise like that. The LV is concentric shape, like a circle. The RV is crescentic shape. The RV free wall here is much thinner, about 2 to 3 millimeters, compared to the LV free wall, which is 8 to 11 millimeters. And the LV has these circumferential fibers that go around in the circle, and they provide the majority of the systolic force. The RV lacks these and relies predominantly on the longitudinal fibers instead. They're functionally different. The RV is much more compliant. It's like a floppy balloon. And the RV myocardial energy expenditure is much less, about 1/5 of the LV. And so to understand, again, the role of these ventricles and their function, it's helpful to go back to first-year medical school and the pressure-volume relationships of the ventricles. So at this point here, the mitral valve opens, the LV fills, and then the mitral valve closes and the LV begins to contract. And there's a clear period of what's known as isovolemic contraction. That means the LV is contracting, pressure is going up, but no volume is being ejected. The aortic valve then opens, blood flows out, aortic valve closes, and then the LV starts to relax. However, no blood is being ejected or filling. This is known as isovolemic relaxation. So if you look at the RV, turns out there's no clear period of isovolemic contraction or relaxation. When it starts to contract, blood gets ejected. When it starts to relax, blood gets ejected. Much more efficient. The question is this intrinsic to the RV and the LV, or does it have anything to do with the pump the circulation that these ventricles are pumping into? So what if we took an RV and hooked it up to a system with an increased RV afterload, for example, pulmonic stenosis? Well, then the pressure-volume relationships look very similar to that of an LV with clear periods of isovolemic contraction and relaxation. What if we took an LV and hooked it up to a low-pressure circuit, for example, after a mustard repair, where now the LV is pumping into the low-pressure pulmonary circulation and the RV is pumping into the high-pressure systemic circulation? The LV now looks very similar to that of the RV. So the function and the characteristics of these ventricles depend highly upon the circulation that they're pumping into. So to understand RV failure, it's important to understand how a pump in general works. So imagine you have a tube filled with blood, and blood is flowing. And now you add a pump. So when you add a pump, you increase the flow through this pump. And When you do so, the pressure before the pump goes down, and the pressure after the pump goes up. That's basically what a pump does. So imagine that this is your right ventricle, and therefore it's pumping into the pulmonary arteries, and it's draining from the systemic veins. And so if we induce RV failure, what will happen? Well, first of all, the flow will go down. And when the flow goes down, there's less flow to the left side of the heart. The left side of the heart then pumps out less blood. You have decreased cardiac output. And these are the symptoms of decreased perfusion. So dyspnea, chest pain, and in more severe cases, lightheadedness, syncope, and frank shock. Additionally, this pressure difference will now become less, and the systemic vein pressure will go up. You get increased venous congestion. You get lower extremity edema and ascites. And these are, again, the signs of RV failure. So the important question that's come up a lot is, does RV failure occur because of an intrinsic problem with the RV, or is it secondary to something else? Do the signs of increased venous congestion, lower extremity edema, are they secondary to problems with the RV? And so this was studied many years ago in the 1950s, where they took animals and actually charred the right side of the heart, trying to induce RV failure. And so what they wrote is a red-hot soldering iron was laid repeatedly all over the surface of the right ventricle. And they write that after the right ventricular wall had been attacked repeatedly with a cautery, only minimal changes of venous pressure followed the most extensive damage to the right side of the heart that we knew how to inflict. So besides the fact that these authors probably would benefit from some anger management classes, this demonstrates that perhaps charring this RV and making it dysfunctional doesn't necessarily lead to RV failure. And again, this was repeated again by Bakos, where again, they charred the right ventricle, and they found that there was still pressure being generated in the pulmonary arterial tree. And thus, an actively functioning right ventricle is therefore not absolutely necessary for the maintenance of a normal pressure gradient in the pulmonary arterial tree. And again, this concept was taken even further. What if we did a full thickness ventriculotomy, cut the heart completely at the ventricle, and then resew it, such that the right ventricle is now electrically isolated. So the right ventricle is electrically isolated from the rest of the heart, and they placed a whole bunch of probes and electrodes. Electrodes in the right atrium, left ventricle, and right ventricle. Pressure probes in the left ventricle and the right ventricle, and a flow probe in the pulmonary artery. And what they did was, when they stimulated the right atrium, it would depolarize the right atrium, and it would lead to depolarization of the left ventricle. But because the right ventricle was electrically isolated, it would not depolarize the right ventricle. In order to depolarize the right ventricle, they had to simultaneously do it independently by the right ventricle. And so you could see here that they would depolarize the right atrium here, which would lead to a depolarization of the left ventricle, and they simultaneously depolarized the right ventricle. And that led to pressure generation in the LV, pressure generation in the RV, and flow coming out of the pulmonary artery. They continued stimulating the right atrium, which led to depolarization of the LV, but then they shut off the right ventricular stimulation, and now the right ventricle is electrically silent. And interestingly, what they found was there was still pressure generation in the LV, and more interestingly, still pressure generation in the RV and flow coming out of the pulmonary artery. So much so that greater than 65% of the pressure development and volume outflow was being generated, despite the RV being completely electrically silent. This was not enough. So years later, Hoffman and his group took hearts, and they literally lopped off the right ventricle. They just cut it off, and instead they replaced it with bovine pericardium, so non-contractile tissue. And what they found was, having non-contractile tissue for your RV free wall, you would still generate RV pressure, and you would still generate flow out of the pulmonary artery. And most importantly, there are patients who lack RVs, and they are doing fine. And these are patients who have congenital heart disease, who have undergone a procedure called the Fontan Procedure, where essentially the systemic veins are hooked up to essentially the pulmonary circulation, and it's the pressure within the systemic veins that drives blood through the pulmonary circulation into the left side of the heart. And these are patients that are living well into adulthood, and they don't have RVs. Which begs the question, if one doesn't need a right ventricle, then how do patients end up in your ICU with right ventricular failure? And the answer to that is that you need a functioning right ventricle in the setting of increased right ventricular afterload. And so the definition of afterload is impedance during ventricular ejection. Essentially, that means there's something in front of their RV. It can't pump. And it's also the wall stress during ventricular ejection. Ways that most commonly RV afterload is increased include increases in pulmonary vascular resistance, decrease in pulmonary vascular compliance, or too stiff, and then the downstream pressure, the left atrial pressure, is high. The LV is particularly tolerant to increases in afterload. So if you clamp the aorta and increase afterload and increase the aortic pressure, you see that stroke volume only goes down minuscule amount. Whereas you do the same with the right ventricle is very intolerant of increases in RV afterload. An increase in RV afterload will lead to precipitous drops in stroke volume and cardiac output. Additionally, the right and left ventricles are essentially roommates in a small New York City apartment, the pericardium. When the right ventricle dilates, it does so at the expense of the LV because it's constrained by the pericardium, and this is known as intraventricular dependence. When this septum bows in, the LV is now unable to pump out blood, partly because it can't fill, and partly because it's altered its geometry and systolic function. And so I have many patients with pulmonary hypertension that are out in the community, they're doing fine, they're at work, they're exercising, yet they have some small insult, whether it be a bleed, an infection, a small pulmonary embolism, and then very rapidly they're in your ICU on vasoactive medicines, intubated. And the question is, why is there such rapid decompensation in these patients? And it has to do with this vicious cycle of right ventricular failure. As I mentioned, the primary problem in PAH is an increase in RV afterload, which, as I demonstrated, reduces RV output. The RV is what fills the left side of the heart, and therefore the LV preload goes down. If the preload of the left ventricle goes down, it pumps out less blood. Additionally, an increase in RV afterload will increase the wall stress of the RV. When the stress on the wall of the RV increases, the RV becomes more ischemic. An ischemic RV cannot pump out as much blood. The RV, again, is like a floppy balloon. When the RV afterload goes up, it dilates. And if you remember Laplace's law, when the radius goes up, the wall stress goes up. Additionally, the tricuspid valve coapses like this. When the RV dilates, it gets pulled apart. You get more tricuspid regurgitation, and this leads to less effective RV output. Also, when the RV dilates, as I mentioned, the RV septum bows into the LV, and that causes a decrease in LV preload. It cannot fill as much. Additionally, that septal shift alters the geometry of the LV and reduces systolic function and contractility, leading to decreased LV output. Part of the LV output is your coronary circulation. The RCA blood flow goes down, making the RV more ischemic. This goes round and round and round and round and round. You get cardiogenic shock, and that's bad. This is important to realize, partly to prevent this from happening, and also when this starts to happen, to know how to stop it, to prevent its progression and basically pull these patients back from the cliff. There are things that we do in the hospital for other patients that are very harmful to patients with pulmonary hypertension, specifically giving them lots of fluid. This leads to more RV dilatation, more RV wall stress, more tricuspid regurgitation, more septal shift, and will lead to actually paradoxical worsening in hemodynamics. Also, intubation is extremely high risk for these patients. These patients require often sedatives, and that will result in vasodilation of other blood vessels. Blood goes to their kneecaps, not to their RCA, and these are patients that will have a cardiac arrest during induction. So the foundation of the diagnosis and kind of characterization of PH is the right heart catheterization. Essentially, through a vein in the neck or through the femoral vein, we advance a catheter through the right-sided chambers, the right atrium, right ventricle, into the pulmonary artery, and we measure the pressures, the right atrial pressure, right ventricular pressure, PA pressure, and ultimately the wedge pressure, which is a surrogate for the left atrial pressure I'll discuss in a little bit. We're able to measure cardiac output with this, and then based on our equation, we calculate the pulmonary vascular resistance. These are all the things we measure. This is calculated. So this is a question I often ask. Which hemodynamic parameter does not correlate with survival in patients with pulmonary arterial hypertension? Is it pulmonary vascular resistance, right atrial pressure, mean pulmonary arterial pressure, or cardiac index, which is your cardiac output relative to your body surface area? So it turns out the answer is C, and you probably are scratching your head because I just told you that the definition of pH is a mean PA pressure greater than 20. So you would think if I have more of this, that would probably be worse. And understanding this concept is key with respect to understanding pH and its therapy. So here are two patients, patient A and patient B. Patient A has a pulmonary pressure of 90/25, systolic diastolic, with a mean of 45. And patient B has a PA pressure of 45/20, systolic diastolic, with a mean of 30. And you think, all right, clearly patient A is sicker than patient B. The pressures are higher in A than B. But it turns out when you look at the rest of the hemodynamic data, the cardiac index for patient A is 3.2 versus 1.4 for patient B. A normal index is about 2.5 to 4. So this is dangerously low, while this is normal. And the right atrial pressure is normal here, about 4, and dangerously high at 24 in patient B. So patient A is probably a patient out in the community, a little bit short of breath. Patient B is someone in your ICU who's very sick, passing out, and probably in shock. And to understand why this occurs, it's helpful to look at the natural history of pulmonary hypertension, using this equation as our guide. And to make this a little bit simpler, I'm going to remove the left atrial pressure aspect. So pulmonary arterial hypertension is a progressive vasculopathy where you have an increase in pulmonary vascular resistance over time. Initially, you have your right heart able to maintain its cardiac output. So if the cardiac output stays the same and the pulmonary vascular resistance goes up, that means your pulmonary pressure will go up. And this is the patient who's asymptomatic and doesn't really realize they have pulmonary hypertension. As time goes on, the pulmonary vascular resistance continues to increase, and now the right ventricle is unable to perform its job and cardiac output starts to drop. When cardiac output starts to drop and pulmonary vascular resistance rises, you now have a plateauing of the pulmonary pressures. And this is the patient now who's a little short of breath, walking a block or so. As this continues to progress, the vascular resistance continues to rise. Now the right ventricle is in frank failure and can't do anything, and now you have a paradoxical drop in your pulmonary pressures. So when you have a decrease in your pulmonary pressures, you don't know if you've gone this way and have an improvement in your situation, or if you've gone this way into frank RV failure and are in a worse situation. And it's important to note that this decrease in cardiac output are the cause of your symptoms of low perfusion, dizziness, passing out. And then right here is a right atrial pressure. You see a massive rise at the end. These are the signs of symptoms of congestion. Again, with this diagram that I drew before, this is your decrease of cardiac output, signs of decreased perfusion, and your increase in right atrial pressure, the signs of increased, the cause of your increase in edema and ascites. So the unfortunate term pulmonary hypertension implies that the problem is the pressure, when in reality, as I mentioned, it's not the pressure that's the issue. So I've suggested maybe we should change this term from pulmonary hypertension to the elevated right ventricular impedance syndrome, or ERVIS. No? Just in case, I've already copyrighted it, so it's mine. Just kidding. But the essential aspect is that treatment for pulmonary hypertension is different than that of systemic hypertension. In systemic hypertension, the high blood pressure is the actual problem. It is the high pressure that is damaging the blood vessels that is causing organ dysfunction. Whereas in pulmonary hypertension, it's not the pressure that's the problem, it's the fact that the right ventricle can't pump. There's something in front of it. And so the treatment is really to get the system working better and more efficient. And so with respect to treatment, the first question is that of vasoreactivity. And during the right heart catheterization, we often administer a short-acting vasodilator. It can be epoprostenol, adenosine. Most commonly, we use inhaled nitric oxide. And a vasoresponder is someone who drops their mean pulmonary arterial pressure by greater than 10 to less than 40, basically close to normalizing, without a concurrent drop in cardiac output. So again, this equation that will haunt you. And to make this simpler, we'll remove the left atrial pressure. If the pulmonary pressure drops and your cardiac output does not change, or at least does not go down, that means that your pulmonary vascular resistance has gone down. So this is a test to see, does your pulmonary vascular resistance immediately go down? Because if it does, you are more likely to have a sustained beneficial response to a calcium channel blocker. And this was demonstrated by Stu Rich in 1992, where he took patients who were at the time called primary pulmonary hypertension, and he gave them, he did catheterizations and gave them calcium channel blockers as the short-acting vasodilator. If they were not vasoresponders, he did not give them calcium channel blockers and he sent them home. And this is their survival. You could see very poor, about 40% at 60 months. And these are two historical cohorts in comparison. If, on the other hand, they were vasoresponsive, he gave them calcium channel blockers, and you could see significant improvements in survival, close to higher than 90%. So the important fact here is that if you look at the underlying pathology, this really just means that the major cause of the pulmonary hypertension is active vasoconstriction. Because if you give a short-acting vasodilator, the only thing that's going to get better is active vasoconstriction. You're not going to undo remodeling. You're not going to remove plexiform lesions and thrombotic lesions. They're looking for the phenotype of active vasoconstriction. And therefore, a drug that merely vasodilates should be sufficient. However, this test should really only be done in those who are quote-unquote primary. So these three groups, idiopathic, heritable, and drug and toxin-induced. And this is a very small subgroup of patients, as I mentioned. And then it's also been shown that of that subgroup, only 13% are actually vasoresponders. And of those, only half remain vasoresponders at about a year. Which means that a very small percentage of patients who have pulmonary hypertension should actually be on calcium channel blockers. So what do we do? Well, prior to 1995, the answer was nothing. It was diuretics, anticoagulation, things that didn't really work that well. And then in 1995, intravenous epoprostenol was approved. Epoprostenol is the same as prostacyclin. It has a very short half-life, 3 to 5 minutes, and for that reason, patients who have this in the outpatient world require a continuous pump and a central catheter. And it's an extremely effective medication. And this is the seminal study in the New England Journal. 80 patients with severe pulmonary arterial hypertension, or in this case, primary. At 12 weeks, there was a significant survival difference. All the patients on epoprostenol survived. 8 patients in the conventional therapy died. But as you can imagine, the administration of this medicine can be quite cumbersome. It's a central line, it's a continuous pump. If it stops, there are a lot of issues. And so for those who had milder disease, this was pretty significant, severe therapy. And then in the early 2000s, the first oral medicine was approved, bosentan. And then since then, we now have 12 FDA-approved therapies for pulmonary arterial hypertension. They come in oral forms, inhaled, IV, subcutaneous. And they target this trinity of pathways that I mentioned early on. We have the endothelin receptor antagonists that block endothelin. These are oral medicines, bosentan, ambrisentan, and macitentan. In the nitric oxide pathway that result in cyclic GMP, we have phosphodiesterase 5 inhibitors that prevent the breakdown of cyclic GMP, sildenafil and tadalafil. We also have the soluble guanylate cyclase stimulator riociguat that helps convert GTP to cyclic GMP. In the prostacyclin pathway, we have the actual prostanoids, epoprostenol, treprostinil, and iloprost. And then we also have the IP receptor agonist, selexipag, in this pathway. It's important to note that these therapies are only approved for PAH, group 1, not the other ones, with the exception of riociguat for inoperable CTEPH. So these therapies really are just for this small subgroup. And so the way these therapies used to be used, particularly for milder disease, is you would give an oral therapy to a patient. You would evaluate them at a year or 2 years and see what happens, and then consider adding a second one later on. But it turns out that most of these patients, essentially all of them, would progress and they would require a second therapy. And the question was asked, well, what if we gave them both at the same time at the beginning? And this was the AMBITION trial that was published in 2015, where patients were randomized to tadalafil, which is a phosphodiesterase 5 inhibitor, versus ambrisentan, which is an ERA, versus both of them at the same time. And what they found was giving combination therapy compared to just one resulted in decreased adverse events, things like hospitalization, worsening functional class, survival as a composite endpoint. And this is the concept of what's called upfront dual oral combination therapy. Which now begs the question, well, if 2 is better than 1, what if we do 3 instead of 2? And this is the Triton trial, which is, I think, completed. But it's tadalafil, which is a phosphodiesterase 5 inhibitor, macitentan, an ERA, plus selexipag, which is an oral IP receptor agonist, versus these 2 medicines and placebo. And the primary endpoint is looking at pulmonary vascular resistance. So stay tuned. So what's happened to survival with respect to these therapies? This is the original NIH registry. You can see 1-year survival, about 68%, 3-year survival, 48%, pretty dismal. Since then, survival rates have improved significantly. Upwards 90% 1-year survival in these registries, 75% 3-year survivals. And as you can see with these dates, this is prior to many of the therapies that we have, and especially prior to the concept of combination therapy and triple therapy. So when giving pulmonary vasodilators, there's some considerations. The first is not only do they decrease pulmonary vascular resistance, they also decrease systemic vascular resistance. So you must use them cautiously in those who are hypotensive. Also, it's important that these medicines should not be withdrawn abruptly. If they stopped immediately, you can develop what's called rebound pulmonary vasoconstriction and pulmonary hypertension. These medicines need to be gradually weaned, the oral medicines, and particularly the IV and subcutaneous medicines. This is a question I ask my fellows all the time. What happens when a PAH patient in the ICU receiving continuous IV epoprostenol loses all IV access? And the answer is this. You have manure and a fan. The point is, it's extremely important when starting these therapies that there be a backup plan. So if a patient is receiving these therapies in the ICU, they must have 2 IVs, one for the IV epoprostenol, one if that IV stops working, because you don't have time to search for another IV. Additionally, patients who are out in the community who have these pumps, they all have my phone number because the second that pump stops working, which doesn't happen frequently, but if it does, they need to be at an emergency room getting that therapy immediately to prevent that from happening. There's also worsening VQ matching, and you have to be cautious in those who are hypoxemic, and especially those who have intrinsic lung disease. So these are your lungs, ventilating these alveoli, and the blood going by them. If you have an area of the lung that is poorly ventilated, let's say you have fibrosis or a mucus plug, this area will become poorly ventilated and hypoxic, and your lungs are smart. It will vasoconstrict this area right here, allowing blood to go to the good area. This is what's known as VQ matching. You're matching the ventilation to perfusion. If you now administer a systemically administered pulmonary vasodilator, you now dilate everything, and you remove that compensatory mechanism, and you now have blood flowing by the poorly ventilated hypoxic region, and that's known as VQ mismatch. One way to circumvent this problem is to actually administer the medicine through the inhaled route, and now you are preferentially pulmonary vasodilating areas of the lung that are well ventilated. So only these vessels will become dilated. This is why, for example, we use nitric oxide in patients with severe ARDS. We are trying to improve gas exchanges and such. And then finally, there's an increasing pulmonary capillary pressure and the concern for pulmonary edema with those who have left-sided disease and elevated left atrial pressure. So if we have high pressure on the left side of the heart, that means there's high pressure in the pulmonary veins and high pressures in the pulmonary capillaries, and assume that there's increased vasoconstriction here as well. If we now give a pulmonary vasodilator, we remove this constriction, more blood flows through here. This results in increased pressure in the pulmonary capillary and pulmonary edema, and further increases in left atrial pressure, which is the last thing you want to do for these patients. And this has been studied. IV epoprostenol in systolic heart failure was stopped early because it increased mortality. Bosentan in ERA resulted in increased CHF exacerbations in systolic heart failure. And this is particularly important for the subgroup of patients with left heart disease who have heart failure with preserved ejection fraction. So HFpEF, also known as HuffPuff sometimes, is a great mimicker of pulmonary arterial hypertension. HFpEF is essentially having heart failure symptoms, a preserved EF, and evidence of essentially diastolic LV dysfunction. And at least half the patients with heart failure have HFpEF, and this proportion is actually rising. And the risk factors include things like being older, female, having hypertension, diabetes, coronary artery disease, atrial fibrillation, chronic kidney disease, obesity, OSA, and COPD. And, differentiating HFpEF from PAH really depends on the hemodynamics, because with HFpEF, the problem is the left atrial pressure. With pulmonary arterial hypertension, it's the vasculopathy, the increase in pulmonary vascular resistance. And so the way that we estimate the left atrial pressure is with the pulmonary capillary wedge pressure. We snake this catheter into the pulmonary arterial tree, and we lodge it into a branch of the pulmonary artery and occlude this vessel. And now when we occlude this, there is no flow from here to the left atrium, and therefore we have a column of blood with no flow, which means the pressure here has to equal the pressure there, and that's how we estimate left atrial pressure. And so if the wedge pressure is greater than 15, that's considered post-capillary pulmonary hypertension. The problem is after the capillary. That's consistent with increased left atrial pressure. If it's less than 15, we consider that pre-capillary, and in the setting of a normal-ish cardiac output, that's consistent with an increase in pulmonary vascular resistance. So this is actually a patient I saw a couple weeks ago who was admitted here. She was a 77-year-old woman who has a past medical history of hypertension, diabetes, obesity, OSA, COPD, AFib, CAD. And she had been undergone a right heart catheterization at another institution because of dyspnea on exertion. And she had a mean PA pressure of 45, so she has pulmonary hypertension. Her wedge pressure is 14, so this is pre-capillary. Cardiac output is normal, and her vascular resistance is high, greater than 3. She was diagnosed, therefore, with pulmonary arterial hypertension and was started on dual upfront oral therapy with tadalafil and ambrisentan. She then, a few weeks later, presented to our hospital with worsening dyspnea on exertion, hypoxemia, and pulmonary edema. And so the question is, does this patient actually have PAH? I mean, when you're looking at these risk factors, you kind of raise your eyebrow. And I would argue that she doesn't, that she actually has heart failure with preserved EF causing her PH. But then you ask me, well, why is the resistance elevated? I thought this was a problem with left atrial pressure. And the answer is that an increase in pulmonary and left-sided pressures and left atrial pressure will result in an increase in the pressure in the vein and the pressure in the pulmonary capillary and the pressure here. And that increase in pressure will cause endothelial dysfunction, which then causes vasoconstriction and remodeling and ultimately an increase in pulmonary vascular resistance. This is still a problem with the left side of the heart as the underlying etiology as to why this occurred. Additionally, we're like, okay, fine, but why is the wedge pressure less than 15? This is 14. You just told me that, post-capillary has to be greater than 15. This is, 14. And the answer is that a catheterization is a snapshot in time. These are my kids. They are in an airplane. They are being cute. They are behaved. They are being quiet. This is a snapshot in time. And so, when you do this, you have to realize that you're doing a catheterization. They may have been diuresed. They may be calm. They may be sedated. Some other things may be going on. And that the current, more common state is the following, where they may be raving lunatics, in which case the wedge pressure is more than 15 more commonly. And so how would we be able to assess this? One way is to look for clues on the echocardiogram. Because if you have increased pressure in the left ventricle from, say, heart failure preserved EF, this pressure over time will cause concentric LVH. The left side of the heart will hypertrophy to decrease its wall stress. Additionally, if there's increased pressure in the left atrium will dilate. And so if you see these signs, then you should kind of think, well, perhaps this is actually HFpEF-PH. And giving them pulmonary vasodilators will worsen the situation. And in this patient that we saw recently, her echocardiogram did show concentric LVH and a severely dilated left atrium. And in the setting of these risk factors, kind of screaming HFpEF-PH. So it's not surprising that she felt worse with this. So in summary, remember this equation and determines kind of pulmonary hemodynamics. That pulmonary arterial hypertension is not the same as pulmonary hypertension. Pulmonary hypertension is a mean PA pressure greater than 20. Pulmonary arterial hypertension is a subset of PH, a very specific vasculopathy. You should consider that very specific vasculopathy in high-risk populations, specifically those with, say, scleroderma, congenital heart disease, portal hypertension. Be cognizant of the vicious cycle of RV failure, A, to prevent it from ever occurring, and once it occurs, to know how to stop it. Pulmonary vasodilators are effective treatments for WHO Group 1 PAH. That's what they are approved for. And always suspect HFpEF as the cause of PH when you have the appropriate risk factors and echocardiographic findings. Early referral to a pulmonary hypertension program is essential. If you have any questions, email me. Thank you.
Change that has occurred in the native Tibetan people that allowed them
Yeah, I prepared for that question, actually. I don't know, is the first answer. But again, it's unclear. There are clearly many people that live at altitude, and not all of them, have this vasculopathy and PAH. And the thought is that this is kind of a two-hit hypothesis where various injuries increase your probability of resulting in this problem, whether it be genetic or whether it be environmental. Diseases like scleroderma, portal hypertension, or drugs. So some people are predisposed to it for whatever reason, but there clearly is a higher incidence in those populations, and particularly in those who go to altitude. So when we assess for patients who have PH, I always ask their history and specifically have they lived at altitude for a while, because that is one of the hits that they can have with respect to the development. With respect to those two populations, I don't know.
Thank you very much. Thank you for making